Hyponatremia is a common and important electrolyte imbalance that can be seen in isolation or as a complication of other medical illnesses. Hyponatremia is defined as a serum sodium concentration less than 135 milliequivalent per liter. Hyponatremia represents an excess of water relative to sodium in the plasma, leading to a reduction in plasma osmolality and subsequent movement of water from the extracellular fluid into the intracellular fluid. Acutely, this movement of water can result in cerebral edema, increasing the risk of seizures and even brain herniation. The diagnostic approach to hyponatremia is illustrated here. It is first necessary to measure the serum osmolality, to evaluate patients with hyponatremia, to determine if there is an associated tonicity imbalance. Patients with hypertonic hyponatremia are categorized diagnostically into 3 groups, depending on their clinical volume status: hypovolemic, euvolemic, and hypovolemic hyponatremia. PseudoHyponatremia is a very rare situation in which the serum sodium concentration is found to be low, but extracellular fluid osmolality and tonicity are normal. The low sodium concentration is an artifact due to accumulation of other plasma constituents, either triglycerides or protein, in plasma. The measured serum osmolality is normal, but the calculated osmolality is low because of the artifactually low serum sodium. Hyponatremia with hypertonicity is another special case of hyponatremia, most often caused by severe hyperglycemia in uncontrolled diabetes mellitus. The sodium is low because of transcellular shifting of water, but both tonicity and measured serum osmolality are very high. Because glucose is an effective osmol, the high glucose concentration causes water movement from the intracellular compartment to the extracellular compartment, thereby reducing the extracellular sodium concentration. Consequently, the sodium concentration decreases, even though the tonicity of the extracellular volume is increased. Administration of hypertonic mannitol may also cause hyponatremia with increased tonicity. This is less common than hyperglycemia, but the mechanism is the same. Hypovolemic hyponatremia occurs with renal or extrarenal volume loss and subsequent hypotonic fluid replacement. The reduced blood pressure results in an increase in ADH secretion by the pituitary, limiting free water excretion. In this setting, the body sacrifices serum osmolality to preserve intravascular volume. Hypovolemic hyponatremia commonly occurs in the edematous states of cirrhosis and heart failure, and rarely in nephrotic syndrome. In these settings, a decreased effective arterial blood volume occurs despite an overall increase in extracellular volume, resulting in ADH secretion. The urine sodium concentration is often low in edematous states because the kidney is abnormally retaining sodium. Patients with advanced renal impairment, whether due to severe chronic kidney disease or acute kidney injury, may be unable to dilute their urine and are prone to develop water retention and hyponatremia. Syndrome of inappropriate ADH is characterized by low plasma osmolality, hyponatremia, low urine output with concentrated urine, elevated urine sodium, and clinical euvolemia. The post-operative state is often associated with an increased release of ADH. A number of commonly used medications may produce this syndrome, either by increasing ADH release, exerting an ADH effect on the kidney, or potentiating the effect of endogenous ADH. Whether hyponatremia is symptomatic depends on both its severity and acuity. Acute hyponatremia can result in marked neurologic symptoms, even with relatively modest hyponatremia, due to acute brain cell swelling and subsequent rise in intracranial pressure. Early symptoms include headache and decrease in attentiveness, which can lead to lethargy, disorientation, and nausea. The most serious symptoms include marked confusion and decreased levels of consciousness, vomiting, seizures, coma, brainstem herniation, and death. Chronic hyponatremia is often diagnosed on routine electrolyte measurements. Patients are often asymptomatic, as the brain has adapted to the surrounding hypertonicity. Subtle abnormalities, such as mild concentration and cognitive deficits, as well as gait disturbances that can lead to falls, may be present. The initial laboratory assessment should include serum and urine electrolytes, and serum and urine osmolality. In clinical practice, ADH levels are not measured, and urine osmolality is used as a surrogate for ADH activity. Additional testing, such as thyroid and adrenal function tests, may be warranted in the appropriate context. The goals of treatment of hyponatremia are to carefully correct the serum sodium concentration toward normal and to correct any coexisting alterations in the ECFV. Definitive treatment demands finding and treating the specific underlying cause of impaired renal water excretion. Sometimes, diagnostic evaluation and treatment of hyponatremia must proceed simultaneously. Acute, severely symptomatic hyponatremia is a medical emergency requiring rapid intervention. Treatment of chronic asymptomatic hyponatremia must be approached cautiously, because overly zealous treatment can lead to serious consequences.